our first speaker. He is also the president of the College of Family Physicians Singapore, Dr. Wong Tianhua. He will be sharing with us tonight on the care protocol, specifically on the health plan as well as GPFIRST. Dr. Wong, please.
Thank you very much, Nelson. Can you hear me?
Yes, loud and clear.
All right. Hi, everyone. Good evening, everyone. Thank you for coming to the Healthier SG webinars on care protocols. And if you see my welcome screen, it looks a bit familiar because I've designed it after the Netflix homepage. And today we are in season 2. All right. In case you have missed it, season 1 ran from 2nd May to 27 June of 2023 on Tuesday nights. And we are here on season 2, exciting season 2 on Wednesday nights for all you Wednesday nighters out there. Every Wednesday nights from 9:30 to 10:30 p.m. And today we're going to do Healthier SG webinar on the health plans and GPFIRST. Let's move on. Right, and as you saw earlier, this is the schedule for the next 5 weeks. Take note that on 18th October, there is a break because of another very important webinar in the afternoon. First thing to note is that Season 1 had 9 episodes. Now Season 2 is only 5 episodes. So what happened? We killed off all the bad guys. No, okay, because we did it Singapore style, it is now more concise and more efficient. We are compressing 2 topics into 1. So we're actually getting better at it. The other thing to note is that the speakers here are all our college council members. So this whole thing is run by family physicians for family physicians. And I'd like to thank Dr. Julian Lim, our council member, ex-council member, but also the head honcho for this whole series. And he was responsible for planning the whole thing. And before I move on again, I'd like to thank, people from the Ministry of Health, MOH, especially the Primary and Community Care Division. We have also colleagues from the Healthcare Finance Division, the Population Health Planning Office, Hospital Services Division, the Agency for Integrated Care, and the MOH Office for Healthcare Transformation, or MOHT. Yes, and this is the other slide that you need to take note of, which is very important, right? This is not part of this series, but additional 2 webinars on annual service fee, which will be, there'll be 2 on the 14th October, another one on 18th October, all right? This is very important. Take note of the timing, take a screenshot. And very importantly, the subsidized drugs webinar, all right, in November, 9 and 11 November. This one I also want to attend, okay? A lot of questions were asked on this one. So please take note. Okay, so we are here today, season 2, episode 1. And I'm Dr. Wong Tianhua, the president of the College of Family Physicians, and welcome on board. Where are we now? You haven't noticed, Healthier SG actually commenced on 5th of July, 2023. And benefits are already being rolled out, right? For the patients, they include things like the health plan consultation, free screenings according to the Screen for Life on Health Promotion Board, and the vaccinations that are recommended by HPB as well. Patients have started to enroll with clinics who are on Healthier SG, and you as a doctor can start scheduling health plan consults for your patients as a routine. How many people have already enrolled? Straits Times report on 11 September, right? Minister says about 300,000 residents have already signed up for Healthier SG. So it seems like, we're on target, things are moving. So Healthier SG care protocols. At the launch, the Healthier SG care protocols will have an initial set, all right? And this includes diabetes, hypertension, and lipid disorders, and lifestyle-related areas such as cigarette smoking and weight management, right? This is a limited set, but it will be expanded in future. So what's the purpose of a care protocol? It's really to standardize care delivery, right? We have to know what are the standards required for looking after chronic diseases, and what are the data points we need to monitor and better care for our patients. The standard required is not just the minimum standard, but it's actually the standard expected of us GPs to provide the best care for our patients. It's a high standard and encourages all GPs to upskill and to deliver better care. right? And the care protocols is to harmonize all these processes, right? We are a choir, we have to sing the same song, basically. So additional care protocols will be developed in future in the next 2-3 years. I just want to highlight the care protocol sub-work group members, right? All these hardworking people. First thing to know is that they are spread of family physicians across both private and public sector, and all working full-time family physicians, right? And you can be assured that all the care protocols are well thought out and operational. So if you look at primary care pages at the website, primary care pages over there, you just click the screen grab, you can actually see that the Healthier SG care protocols are online and live. If you click on them, you can see everything in detail. They're divided into 3 categories, right? Under preventive care, for example, under vaccination, BMI control, cancer screening, smoking cessation. Under chronic care, you've got pre-diabetes, diabetes, hypertension, and lipid disorders, and multimorbidity. And 2 administrative kind of section, which is this evening's discussion, right? Health plan and GPFIRST. So what's the concept of the health plan? Well, it's a well visit kind of like, patient's going to come to you, and they're going to come to you when they're not having a complaint, right? They're not coming to see you because of a pain or some diarrhea or fever or COVID, but they're seeing you when, they're kind of well. In fact, a lot of patients so far, a few have come to see me and they don't even know why they're here, all right? Because they went to the CC, someone signed them up and asked them to come to the clinic, and then they promised them $20 NTC voucher, right? So sometimes they even know why they're here, right? So it's up to you, it's doctor driven, right? But at the same time, it's an opportunity for you to have a conversation with the patient. Importantly, a lot of new patients will come and see you, right? Some of them never been to your clinic, never registered, they're going to step in new. And part of this is really the idea of Healthy SG, right? To bring patients through the door of the GPs for you to work the health plan for them. The advice you give will be uploaded to the patient's Health Hub app, and that information will be portable. So the health plan aims to empower enrollees to take charge of their health, right? It facilitates health actions that lead to achievement of health goals, and it supports both the doctor and the community. Health goals are personalized and meaningful to the enrollee to promote patient empowerment and nudge health improvements, right? So it's kind of like first time, in the old days, Health Promotion Board will put up big posters to get everybody to quit smoking. But in the health plan, the patient walks to you, you assess the smoking status, you tell them you're smoking too many cigarettes, you encourage him to stop for a certain date. So it's really personalized for the patient to that level. It serves as a communication tool between enrollees and their GP. Next is Health Hub. What's Health Hub? If you haven't downloaded the app, right, it's an app, right? You should do so. But, if you want to see your COVID vaccination status is on Health Hub, right, on the app. So I think a lot of us already have Health Hub. Upon enrollment, doctors should initiate a first discussion with enrollees to develop the health plan, and the details in the health plan will flow automatically into the enrollee's Health Hub account, all right, for GPs who are using Healthier SG compatible CMS systems. Key points from the digital version of the health plan as submitted by the GP will be shared with classes over time to enable them to support enrollees for activities. Actually, what this means is that once you're on Healthy SG, once you start keying data and it flows in the Health Hub, you are contributing to NEHR, right? Okay. Anything that you submit, right, in the health plan will flow, the data will be NEHR, meaning that other healthcare providers will have access to those data. I need to talk about the primary care digital services, the PCDS, all right? The PCDS is actually a plan B, kind of like a plan B, right? But plan A is your Healthy SG ready CMS in your old clinic. But if you don't have that or it's not ready, you can turn to the PCDS. Where is the PCDS? It's actually on the PRPP website, all right? You log into the PRP website, you can see there's a section for PCDS. You click that, you log in with the SingPass, and you will get into the Healthier SG homepage, which is quite simple, right? For those clinics who are already enrolling patients, you will see a whole list of patients who are enrolled with you. I primarily use PCDS on a daily basis when I want to enroll new patients, right? If the patient has not enrolled with me and walk in opportunistically, I said, join the plan, enroll, I'll go into PCDS, click the enroll new patient tab over there on the right, and key in the patient IC and ask them to agree. And once they enroll, an SMS will be sent to the handphone to confirm enrollment. But also on PCDS, you can do goal setting, right? And you can have all kinds of goals. You can add goals, right? For example, in this case, lifestyle goals for weight management, smoking cessation, no diabetes and hypertension. These goals do not auto-populate for every patient. When you see a patient is blank, it's up to you to add them. So if a patient doesn't have diabetes, the diabetes goals will not appear, right? So minimally, I suppose you can talk about exercise goals. You add exercise goals, you can add, exercise 3 times a week or something like that. So at least you can add something to the discussion. At the end, there's also what you call a free text box. A free text box allows you to record actual discussion with the patient in free text. So in this case, you can see that John had a good control of asthma using preventive inhaler, but the asthma protocol is not up yet. So in a sense, well, you can say, I've encouraged John to quit smoking, or, he is going to, he had his flu vaccination today on this date, or I'm going to give his pneumococcal vaccination on this date. So once you key that in, this free text data will be uploaded to the patient's health hub, and he can show it. He can use it as a record, right? It's like a record book. So here's the Health Hub app, right? That's the logo, right? You should download it. Once you log into your Health Hub app, you can see your name. You can also nominate caregivers or your dependents, right? You can see the names of your dependents on your Health Hub. And if you're on Healthier SG, there's a Healthier SG tab. You click that, you will see a health plan, reflected in the Health Hub app. So all these things that you see, vaccination goals, lifestyle goals, activity goals, they were keyed in by the GP, right? You key them in, right? So it will flow into the Health Hub. So all this talk, now you see, right? All this talk about what CMS to use, why is it so important to have the good IT system, all that discussion in the past 1 year about IT upgrade, this is where it's coming into play, all right? If you have a CMS ready, compatible, HCC compatible CMS, once you key that data, it will flow into the Health Hub app. It's supposed to be seamless. So the health plan, what are the key elements to cover? Things like recommended health screenings, vaccinations, advice on healthier lifestyle changes, and any actions related to chronic conditions. And individual topics will be covered in the rest of the webinar series. So the next thing I want to say, I want to emphasize is that you are keying data into the health plan. That data is going to flow into Health Hub and NAHR, right? So please, all right, it's about time that any data you enter has to be appropriate and accurate, right? So as they say, rubbish in, rubbish out, be very careful. When you're keying in, blood pressure readings, make sure that it's accurate. If it's a few, do an average, right? And make sure that the data is correct. Don't, take a weight, and go off measurement by 10 kilograms, right? Because that will be reflected. So be very careful, because every data that you key in is shared and seen by the patient and other healthcare providers. At this point of time, I also want to emphasize that it is an ethical prerogative that any advice that you give should fall within the scope of acceptable body of practice, as well as supported by scientific evidence. So I feel compelled, basically as a representative of the college, to remind you that you should always exercise and practice within what is deemed acceptable practice. For example, you cannot give unsound advice, right? For example, instead of quitting smoking cigarettes, you ask the patient to try vaping instead. That is even illegal, okay? So don't go from bad to illegal like that, right? Or weight loss advice, right? Don't ask them to take, inappropriate weight loss pills, for weight loss. So it has to be within acceptable body of practice. Stick with the plan, right? The health plan, as they say, is for you to use for the purposes of Healthy SG. Don't use the opportunity, to lock the patient in the consult room and subject them to high pressure sales tactics for 1 hour for your clinic packages. So the history, instead of, what can I do for you? Because patients are not going to come to you with a condition or complaint, right? It's going to be thank you for coming, right? So this whole health plan idea, the visit is going to be doctor driven, right? So you're going to have to plan it out. You're going to, after a few times, you're going to get used to it. It's not going to be difficult, but you get into the gist, right? You start explaining why the patient is here, what you're going to do, and how you're going to go about asking the patient regarding their health status. So you're going to ask things like medical history, family history, any screening history, vaccination history, especially pneumococcal vaccinations for above 65 or your flu vaccination history, right? And other lifestyle factors, in particular, smoking, exercise, alcohol consumption. Physical examination, in particular, you want to have some data points. So I would say your height, weight measurement should be there, should key it in, all right? And your blood pressure readings, you should in the first health plan, you should at least get the blood pressure reading in, because that data will flow into the health hub. And any treatment plans, any lab investigations, any lifestyle changes you can recommend, you can put it into the health plan as well. Referrals as well. And finally, any health goals or follow-up that you want to tell the patient, you can key into the health plan. So what's the timeline for completed health plan? It's recommended that an enrollee's first health plan should be completed within 6 months upon enrollment with the GP, right? And for new patients, you should schedule appointments with them. And actually, a lot of the patients that are walking into my clinic now is being enrolled by the CC, and then just, they make the appointments and they come. The other way to enroll patients is through opportunistically, right? When the patient are coming to see you for cough and cold, you can enroll them on the spot. How often does the health plan need to be updated? There should be regular scheduled check-ins to assess the enrollee's overall health condition and progress. Discuss the progress of patients' health goals and assess if the goals need to be adjusted or any additional intervention required. For well enrollees, right, those with no chronic conditions, an annual check-in should be performed, but their first check-in should be done in person. Thereafter, minimally once every 3 years. For chronic enrollees with at least one chronic condition or at least 2 chronic consults, you need to at least have 2 chronic consults conducted annually, and the health plan should be updated during these 2 visits. For the purpose of the annual service fee, the visits should be at least 3 months apart. So data submission, all right, you can submit data like shared goals. And again, I said there's a free text box for you to key in. So all these are examples of the data that you can submit. Lifestyle interventions, components of diabetes, hypertension, and lipids. But bear in mind, you don't have to be, overwhelmed, right? For patients with no complex conditions, it can be done quickly. You don't have to key in every single field if it's not relevant, right? Only relevant ones for the patient. It is personalized. Financing, GPs will be paid a fixed fee upon completion of the first health plan discussion. The fixed fee can only be claimed once for each enrollee. And when they come for the first health plan discussion, you should not charge a consultation visit separately for that visit. So that's all for the health plan discussion. We can take some questions, or should we just roll on to the GPFIRST discussion?
Thank you, President.
Yes.
I think for all of you who have any questions, you can actually start typing into the Q&A already. We can actually answer along the way.
That'd be good.
Yeah, so I will encourage everyone to just type in your questions in the Q&A. If you have any strong questions, you may raise your hand. We will take them. But I think we are going to transit to the second part of the speech about GPFIRST, and then we can have a combined Q&A at the back. But in the interim period, if any of you have any questions pertaining GPFIRST or health plan, please do type into the Q&A function at the bottom of the screen, and we'll be happy. Our panel of experts and resource persons will be happy to answer them and type back. Right. So, President, will you be able to deliver a second half on GPFIRST?
All right, let's go on to GP first. And I am in good time.
Yes, very good time. Thank you.
Okay. Okay, GP first program. So what is GP first? GP first means that you should see the GP first lah. All right. For what conditions? It's actually an A&E program. All right. So instead of going to the accident and emergency, where some people call it anything and everything, all right, go to the GP first. All right. So that's the concept. So I'm sure a lot of you has already used the GP first program. I have. And the aim is really to encourage patients with non-urgent, mild to moderate conditions to first seek treatments from the GPs instead of going to the A&E. All right. There are urgent care centers or the emergency departments. And with the GP first program, if they see the GP first, all right, the GP refers them to the A&E, they will get queue priority and also $50 off from the fees. All right. So you're trying to funnel patients to go to the GP first. It was first piloted by Changi General Hospital back in 2014, but as of this year, all existing acute hospitals have implemented the GP First program. So all the A&Es, with one exception, is KK Pediatrics, all right? The KKPs does not have a GP First program. So with the launch of Healthy SG, all GP clinics participating in Healthy SG will also be offering GP First. That's basically it, but let's go on. Okay, well, I don't have to tell you lah, right? I mean, when you're a GP, you know, you're seeing every patient as they come, and some of them, you know, will need to be referred. If you're better managed in a GP clinic, it's much better, right? It's shorter waiting time, there's lower charges. Now A&E is not cheap, you know, it's $120, right? So it's actually not cheap to go to A&E. So it's better to go to the GP. But if there's any urgent cases or any urgent emergency cases that needs to be referred and it's necessary, then at least patients will have a subsidy of $50 off with the GP First program and seen with a bit more priority over non-emergency cases. This is a referral pathway, which, okay lah, I didn't design this slide lah, okay? There's no need for referral pathway. Basically, anybody who comes to see you as a GP, if they have an emergency life-threatening conditions, call 995, right? Okay. If there's something urgent that you cannot handle, you think it needs to refer on to the A&E, then please do so using your usual routes, right? But before they do, the step here is to fill up the GP First referral form. The GP First referral form as a hard copy should be brought by the patient to the A&E, and when they see that, it's $50 off. At the hospitals, they will also test whether your referral is appropriate or not. And one interesting marker for that is that if you refer a patient to the A&E and no tests were done, no screening, no test or procedure was done, and they were referred on to SOC, then it's likely that your referral was not appropriate, right? But if they went to the A&E and they had to do an X-ray or a scan or some blood test, then yeah, likely that your referral was appropriate or some kind of procedure. This is my GP First form, which actually that I have right now, which is a bit out of date because it's only CGH and Sengkang Hospital. But you can see that the form is one page. It is I think it's a double. I think there's a copy at the back lah. It's a pink and a blue copy at the back. All you need to do is stick the patient's label there, write the brief history and findings and diagnosis, put your CHOP with the MCR number there. All right, your CHOP and MCR number. Okay, and make sure the patient brings this GP form with them. Basically, the GP First form is worth $50, all right? With no form, no $50 off. FAQs on GP First. Can GPs refer patients to EDs that the GP is not partnered with if patients prefer? Yes, they can go to any ED which will honor the GP First form. Question 2, can patients use the referral form at a different ED from what is stated on the referral form? Yes, if you write there Sengkang Hospital, they go to Kutik Part, it will be honored. What happens if patient was not given the hard copy form or forgets to bring the GP First referral form? Sorry, no $50 off, right? That hard copy is his street price of $50. What happens if the GPFIRST referral form is incomplete? They will still honor it, but you will get a follow-up call from admin the next day to complete the form and all that. So it gives you more trouble. Will referring GPs receive follow-up information on the patients they have referred? Unfortunately, no. You will not get any summary from the emergency department. The only way to check it is to go into NAHR to check on your patient's conditions after they've been referred. So these are contact numbers for participating hospitals. You can see the slides. I think it will be available on the college website. As you can look for the webinars over there and check out the numbers. So this is something provided by A&E, and it's basically non-exhaustive. What are the kinds of conditions that you shouldn't refer to the ED? Things like headaches with no red flags, giddiness, things like that. Yeah. We spend 2 seconds to get the slides. Okay, next. Dengue is another one, right? Without red flags, you don't have to refer to the A&E. So they gave us a case discussion. 40-year-old male Indian, for example, with non-exertional poking chest pain, and the patient is worried and scared of AMI. There's no reproducible pain on palpation and no known CVS risk factors. You do an ECG, which is normal. Do you refer patient to A&E? Yes or no? Or give him $50, to buy copy. Right. It turns out that you can use things like MD Calc, for example. You plug those figures in, and it's online, and you actually come up with a score 3% cardiovascular risk. Outpatient evaluation is probably only what's required. So you can just tell a patient, you're 3% cardiovascular risk. If you go to A&E, they're gonna wait 6 hours, and then they're gonna refer you to a cardiology, and nothing's gonna be done. Or would you rather go home and sleep, and then we arrange for urgent cardiology appointment in the next available date? So these are some of your available clinical decision pathways. Again, when it comes to A&E, always a big kiasu, all right? Patient comes with epigastric pain, you do an ECG, you see all these ST T-wave changes, all right, call the ambulance. All right, so in the end, it's still up to your clinical sense and your appetite for risk. All right, nobody is saying that you have to take all the risks. If you're not comfortable with the case, it doesn't look good, please refer to the A&E. So what are the, I think okay, let's go through some of these roles and responsibilities. The first is that the validity, of the form. How valid is it? Can you take the form and go back 1 year later to claim $50? Cannot, all right? It's only valid for 24 hours, up to 0200 of the following day, give and take, right? I don't think there'll be 5 cents, 10 cents, or $50 about this, but it should be within 24 hours. Right? Ask the patient to bring the NIC, especially the hard copy. So even for ambulance cases, all right, they're still eligible for $50 off. So you got AMI, you call ambulance, one life saved, $50 saved also, right? So please throw the form on the patient as the guy gets wheeled out of the clinic into the ambulance, right? Just throw the form at him. Make sure the form is completed, and bear in mind that they only need $120, right? But if they do a CT scan or other specialized investigation, they will charge on top, all right? So it's not $100, $20 flat fee. That's basically it. Thank you very much.
Thank you, Press. Okay, we have a lot of questions who came in, but I'll let you take a short break because I think some of our panelists will invite some of our panelists to answer some of these questions on air live. Azhar, Geraldine, will you be so kind as to unmute? I think it's good to reiterate some of the questions we should answer in the FAQ, right? In on air for all audiences. Right? So there's a lot of questions about GPFIRST versus Peds Engage. Is the KK Hospital Women's A&E also covered by GPFIRST? Azhar, would you like to address that on air, please?
Okay, so it seems like under KK Peds, it's not GP First, it's called Peds Engage. I think that one you need to have a bit more training, you know. There's to be under Peds Engage, a bit of
Yes.
pediatric training for that.
So for Peace Engage, you actually have to undergo an online training. So if you're interested in joining the Peace Engage program, you have to sign up. You can sign up via a PCN where you undergo a training program. It's an e-learning program. And then they will actually add you to their Peace Engage WhatsApp group. There's this WhatsApp group where all the GPs are inside with the pediatrician and the children emergency specialist. And then you'll receive sort of like a guidance. So the two programs are separate. So when Press now said that KK is not in GP First is because they are on a separate program, which is known as the Peace Engage program. So just not to confuse the GP First and Peace Engage. They're similar. If the children goes to you and then you can manage, it's great. If you cannot, you can use the same form to refer them to NUH or KK Peace, where they will receive also a reduction in the pricing of their priority queue. Okay, I wanted to bring a question that's very interesting. So there is this question that came out. They said that the patient comes and consult for chronic review, and then you said just now you mentioned in your talk that you cannot charge above the health plan first visit. Maybe you want to clarify that part again. The patient comes for a chronic disease review or comes for a health plan, but also want to consult the chronic disease or also have acute ARI or this. Is the health plan first visit charge or there's a separate charge according to that?
Okay, so this is it's been raised before in the meeting. I think basically the communications to public is that when you come for your health plan, it's free one. So, you know, when you walk in for health plan, you're not supposed to pay anything. So that's the comms to public. But of course, there are all kinds of permutations, right? Patients are there to see you for COVID. No, not COVID. Okay, ARI or pain or whatever, right? And then, of course, you see them as a normal consult. Then you persistently enroll them in the HSG. The HSG component can be charged on the same day, right? So it depends on the context of what the patient is seeing for. But the idea is that if the patient has made an appointment to you to see for HSG and you do a health plan, it's free. So it's a bit like 6-monthly medical checkup for helpers, right? Helper comes and see you for a blood test, right? For the thing. Then she complains about a rash over here, right? A bit of rash. You give her a bit of steroid cream. You charge for consult. Or you just, just charge the cream and then you bundle everything in, right? A bit like that. So it's up to a bit of discretion to the doctors and how you communicate to the patient. But in the end, you don't want to have a patient complaining to MOH and say, I went for HHG consult. Why is the doctor charging me a consult fee? And then you have to start explaining. But at the point of payment, you tell the patient, right, that you actually came for this, but because we discussed about your, other issues, that actually incurs a separate consultation fee.
All right, good. So in essence, the Healthier SG first visit is itself covered, but anything that is above and beyond the first visit, for instance, there was another acute conditions which require medications, all this, then those will be separately as charged. Accordingly, if they are charged patient to the charged acute or chronic as deemed required, like if there was a consultation or medical beyond the first plan, right? Then another very interesting question which you also hear quite often is that a patient comes, they enroll themselves with you and as Healthier SG, and they come in with a long list of medical problems. They have Parkinson's, hypertension, hyperlipidemia, on follow-up with poly as well as hospitals, all this, but they want to enroll with you. Okay, this question I will throw it up to quite a few of our experts because we have a lot of very senior veteran family physician here, Dr. Fadzil, Dr. Tam Tak Yen, Dr. Sui. I want to hear all your responses, right? So Press, have you met such a patient come in with a long laundry list? You open up NEHR, it's like 5 pages. So what is your response? This patient want to enroll with you for Healthier SG. First time seeing this patient.
Enroll, but I just focus on hypertension, diabetes, and cholesterol, right? Because these are the health plan things that I'm focusing on. I mean, his Parkinsonism or his heart attack or his chronic heart failure. It's there. It's part of the history, but it's not part of the health plan. All right. So you don't have to focus on those things. You just focus on the health plan and discuss, those things that are relevant to Healthier SG. Is that what you would do, Tak Yan?
Yeah, Dr. Tam, a very experienced family physician. Please share your experience when you encounter this patient.
Thanks, Tianhua and Nelson. Just want to remind our participants that Healthier SG, in Healthier SG, the enrollment is essentially primary care enrollment. And I think GPs or polyclinic physicians are equipped to deal with primary care problems, which include all the preventive care protocols, vaccinations, and of course, some of the chronic diseases are also under our purview. It is okay if the patient is currently seeing a specialist for certain medical conditions. The patient can still choose to enroll with a GP or a polyclinic physician. However, if the patient is currently seeing a polyclinic doctor for various chronic conditions, there should be a discussion with the patient on the pros and cons. And I think being fellow family physicians and primary care doctors, we should encourage our patients to stick with their regular doctor and not change doctors that easily. Over.
Thank you, Dr. Tan. Very good words of wisdom. Azhar, are you ready? I would like to invite you to address some of the Peace Engage, Healthier SG questions, which we have a lot.
Yeah, so sorry about that. I
Hey,
forgot
no
to
worries.
unmute the
Great
other
to
set
see you.
earlier.
Thank
Yeah.
you so much. Okay, so let's first upfront. Again, just to reiterate the difference between GPFIRST and Peace Engage, why don't you share with our audiences?
Okay, so firstly, GPFIRST is really for the adult EDs, so that's one, and Peace Engage is dedicated to NUH and KKH children's emergencies. So already the patient groups are quite different, so that's why there's a split in that. And also the other thing is under HSG, the program that's covered is actually GPFIRST. So Peace Engage is not automatically under HSG. And the other thing is the training wise as well. So on HSG, you're already automatically on GPFIRST, but for Peace Engage, you do need additional training, as I think President has mentioned and Dr. Nelson has also mentioned. So if you're interested in that, please do reach out to KKH and NUH Children's Emergency if you're looking at Peace Engage. The other thing is also, I mean, with that training, the criteria is of course also different as well. So again, management of peds versus adults is quite different. So that's probably the third key difference between the two.
The
The
other
other thing,
question we have was the 24 hours referral. Also, we want to check. KK has a women emergency, right? So is that covered under GPFIRST, Peace Engage?
it's actually not. So KKH has a 24-hour urgent ONG clinic, so it's not quite an emergency per se lah. So as we know, KKH is a children's emergency, so KKH program covers just purely the Peace Engage, so it will not cover GPFIRST for the pregnant ladies lah. So GPFIRST really is the other adult EDs. So that will I mean the other EDs including NUH, which has both the children's as well as the adults emergency lah.
Okay, the other question that we have is the timing. Just now, President said valid for 24 hours. Do you want to clarify the timing validity of the GPFIRST form?
I think if it's possible to circle back to the slide, I think there's under the terms and conditions, they do spell out the timing up to a certain time point.
Yeah, my apologies, it's not 24 hours, but it's like up to 2 a.m. or something.
Correct.
Of the
So,
day, if I'm not
so
mistaken,
Dr.
2 a.m.
Pauline Niao, which is one of our aides from the NUHSPCN, has clarified, or rather has shared the correct answer, which is that it's valid for the same day, but if the consult is after 11 p.m., it's until 2 a.m. Okay, so Dr. Pauline also shared with us the answer, which is that the GPFIRST is valid for the same day, and if the consult is after 11 p.m., then it's up to 2 a.m. the next day lah, huh? So that is a time limitation, not really 24 hours lah, huh? Okay.
Maybe I just share the thinking behind it.
Correct, the rationale. Dr. Ruth, thank you.
No problem. With your patients as well, because this would be a patient who has already seen you and you have deemed it to be urgent enough to go to the A&E. So you do want the patient to head to the A&E in a timely manner, and that's why they want it within the day and within a short time period. Because if the patient took that letter, sat at home, waited a very long while before going down and they deteriorated, then don't want any misunderstanding. So that's why there's a time frame. Over.
Okay. Very good answer. Thank you so much, Dr. Ruth. Also a good question. After enrollment, must I do the health plan first before I can give all the benefits for the free screen for life or vaccinations, or can the screen for life vaccinations occur even before I do the health plan? Press?
I think the CMS doesn't allow you to claim for vaccination without doing the health plan first. I mean, if you let's say give a flu vaccine, without the first consultation, then it will be under child's vaccination, and then do the copay. Whereas if you do HSG consult first, and at the same consult you give the flu vaccine is free, right? That's the system that I have, but I think most of the CMS compatible ones are like that as well. Is that correct?
No. Sorry. Dr. Ruth, maybe you want to clarify on this?
Sorry, quick, repeat the question.
Okay, so upon enrollment, does all the benefits automatically come in, or must they do the health plan first before they can get all the benefits, such as no co-payment for Screen for Life and vaccinations?
But I think if you're planning to do a flu vaccination, you might as well try and do the health plan so that you can be explaining to the patient that that's part of the care. It's nice to document and then you can do it. You can do it on the same visit, but in my mind, it would probably make a little bit more sense to have done the health plan and then to proceed with the rest of the task that's done. I'm not sure if only Lian wants to.
Yeah. So I could add on that. Yeah. So I think just to clarify, actually, upon the enrollment of the resident, right, which is when the enrollment status is reflected in the system, actually the vaccinations and screenings, nationally recommended ones, they ought to have been available to the resident already. So it's not contingent on the completion of the health plan. So I think that's something that from policy actually we will be allowing. So I think there might be a need to check with the CMS vendor if there's some difficulties there. Yeah.
Sure. Yeah, so that's very good answer. Thank you. So the moment they enroll with you, you automatically can give suppose you want to do the flu shot today and don't want to do the health plan another day, you can actually give them the flu shot and cover it under the Healthier SG auspice, and then the health plan, all this can be done separately. Also, it's the enrollment that gives them all the benefits, not so much the health plan. And the health plan, but of course you should do what Dr. Ruth and President has said, which is try to do it all in one shot so you can minimize number of visits. Do the health plan today and do all the vaccinations and screening at one shot if you can, if possible. Okay.
I think, yeah, from a practice point of view, I don't dare to give anything before a first health plan, because you haven't reviewed, you haven't asked for history, you got nothing, So the health plan, you need to ask for history. Have you had a pneumococcal vaccine? All that is health plan, So you must well do the health plan first, clear everything out, and then I recommend you to take the flu vaccine. So that's the purpose of the health plan. See?
Okay, correct. Okay. I think Dr. Loh also shared some points about clinic access. So maybe you want to, all of you want to check with your CMS vendor as well on how the system plans out around. All right. Okay. So there are some questions about how long will it take for them to onboard clinics to Healthier SG and CHARS, etc., for new clinics that's set up. What's the usual timeline? Maybe our colleagues from MH can share what's the usual timeline for newly opened clinics who want to join Healthier SG to get everything to be sorted out. Or Dr. Tam can share how long does it take to enroll with a PCN?
There is an administrative process that involves the GP clinic signing up for the various schemes, the national schemes. And then, of course, the HSG requires a signing of a document as well. And then, in addition, there is this thing about committing to being part of the NEHR ecosystem, submission of data, and so on and so forth. I would reckon that it would take at least several weeks for a GP clinic to eventually be onboarded, but I do not know what is the current timeline, because my experience may not be updated with the latest developments in this landscape. I don't know whether our AIC or MOH colleagues can let us know, because I think some of the participants tonight might be people who are thinking about joining Healthier SG, and they need to know that the kind of a timeline to prepare. Over.
MOH colleagues maybe can chime in on the process of being CHARS accredited and all this.
Hi, so I think again, I think similar to what Dr. Tam is mentioning, I think as a ballpark, because I think each case, as in the experience from each GP may differ from case to case depending on clarifications and stuff. But as a ballpark, I think we would typically need 6 to 8 weeks to finish the CHAS plus MediSave accreditation process lah. So do buffer some time for that, yeah, because there are some documentation verification and things like that's required.
If they are not they're not yet on all this CHAS or this, can they get a link with a AIC? Can they still be under AIC, like have a link with an AIC manager, or they must be onboarded before they can have a link to an AIC manager?
I'm not sure if there's any AIC colleagues here, but I mean, I think I'm not sure if Veronica, but I think please feel free to correct me if I'm wrong. I believe that even if they are not CHAS accredited yet, AIC would be able to support the GPs if they have queries. So I believe GPs can still be referred to AIC, but please correct me if I'm wrong. There's some other channels that AIC would sort of direct the GPs to.
Yeah, so maybe before they
AIC
yeah,
do reach out to all the GP clinics.
exactly.
Yeah, so they do, but perhaps our Healthier SG clinics, the PCN clinics, might be more familiar or have more reasons to reach out to their AIC account manager.
Sure. Yep. So the nutshell is while you are awaiting all this process, you can reach out to the AIC manager to get some assistance. You can also reach out to PCN to better understand what the PCN involved. Okay, we have a very good question from Dr. Joyce, right? So they are asking about after the first health plan, during the usual chronic visit, maybe this patient has a hypertension, is due for a review at 3 monthly, whether they tag it under the Healthier SG or they tag it under usual CHAS, and whether there's a minimum number of HSG to be completed per year.
Maybe I start first and
Sure.
rest could jump in. So I think CHAS, Healthier SG is built on top of CHAS benefits. So you can go ahead and claim the CHAS. If the patient was here for chronic visits, do claim the CHAS chronic visit. But at the same time, the care that you've done for the patient as part of that chronic visit, it can be entered in for care reporting. It will meet the Healthier SG care reporting or the annual service fee claim. So those will be captured under. So it sort of serves a dual purpose. If the patient is completely well, no chronic conditions, all you need to do is one annual check-in a year. And this can be face-to-face, it can be through tele means, because you're checking in to make sure that the patient is well and that there is no further need to do any change in conditions, no need for a review, no need for a change of blood test. So that's where Joyce was talking about the 3 years. That is based on a completely well patients, because based on SFL recommendations, for the patients who is young and no other risk factors, you could do the next SFL screen 3 years later. But of course, for some patients, they may not have a chronic condition, but perhaps they are at higher risk and their BP might be a bit borderline. For this sort of patients, even though they haven't been diagnosed yet, you probably want to bring them back in earlier and not wait until 3 years later. So it does depend on the patient that you have in front of you. That's for the well ones. For chronic, then you would have to apply the usual chronic follow-up. And generally, most of our chronic patients will require at least 2 visits in a year for you to review them, review their blood tests and how they're doing, to give them the medications and see if any titration is needed. Over.
Yep. Thank you. Very good. Okay, again, we have questions on complex patients. So we have, again, very good question from Dr. Nathaniel Ng. He's asking about patients who are on follow-up poly for many years and have many chronic medications, like maybe DHL, but now approaches the GP clinic and they want to enroll with a GP clinic. And how should they counsel these patients, especially when the whitelist drug is not out yet? Press, how do you counsel these cases who turn out to you?
So I think one communication issue with patients now is that they think ACSG clinics are polyclinics, right? They think that the GP clinic is equivalent to polyclinic. So, I'm going polyclinic, I enjoy all these things, I'm going to go to my GP, same thing. But even with the medicines coming in future, right, with the whitelist drugs, it's not apples to apples. I mean, the GP clinic is still operating as a private clinic. And I tell these patients that sure, they can enjoy some subsidies on the drugs, but ultimately, you know, when they see me as a private GP, they have to pay for consultation fees. That one, you know, whether you have got a CHAS card and all that, yes, you can have some discounts on that, but ultimately there's a consultation fee charge, and each consultation fee charged by the GP it depends on their own clinic policy. So the difference is actually your consultation fees, you know, I think in that sense.
Okay. So you will do some financial counseling for the patient and let the patient make the decision by laying out the pros and the cons, huh? Yeah. Dr. Tam, how about you? What's your experience when you face with patients who are on follow-up with poly for a long time with a long list of medications and they now want to enroll with you? May I seek your views, Dr. Tam?
Thanks for the question. I think as I've briefly alluded earlier, I think the principle of family medicine is about continuity of care, personalized care by a regular family doctor. And I think for any patient who wants to switch the primary care doctor is something very, very important. It's a serious decision. I think as fellow physicians, we should counsel our patients and ask them what are the reasons why they want to change their primary care doctor. We're not talking about specialist care now, we're talking about the regular family doctor. And we all accept that it could be in the polyclinic or as well as in the GP clinic. So we have encountered occasionally some patients who asked whether they can enroll with us, even though they are consulting their polyclinic physicians. But I think a number of those cases were actually, perhaps they were a little bit ignorant about what Healthier SG is all about, the intentions behind it. And I think if we counsel the patients properly, a lot of them will eventually make the right decision. I think we all need to do the right thing for patient care. And it's not about switching between patients and for one reason or the other. So the reasons behind the switching and the changing of the doctors must be discussed properly with the patients. And it does require a bit of time and understanding on our part to be willing to invest that kind of time to have this conversation with the patients. Let us do the right thing for our fellow primary care doctors in the community, even as we roll out Healthier SG. Over.
Very good answer. So what Dr. Tam said was you should find out the reason for the switch and make sure that the patient really understand it and help the patient to make the correct decision. Very, very good answer by Dr. Tam. All right. There's Lillian, I will need you back online because again, there are questions about the annual check-in fee, which I think you gave a very good answer. May I trouble you to just share your answer on air with our patients? There are questions about the annual service fee.
Sure. So just to elaborate a bit, I think there was a question on whether there's a certain range in time for the annual check-ins to be done, beyond which the ASF will not, the annual service fee will not be claimable. So I think just to reiterate the requirements again, for well patients, because we have indicated that the annual service fee, to clock that, you will require an annual check-in with the relevant data like height and weight submitted. So, and the eligibility for the annual service fee is on a calendar year basis. So for example, in 2024, you have an annual check-in done for your well patient. The data must be submitted and it must be done within that CY for you to be eligible for the annual service fee for your well patient enrolled with you for that year. And then for chronic patients, because the criteria for the annual service fee is 2 chronic consults within the assessment year as well. So again, you need to clock a minimum of 2 chronic consults. The data must also be submitted within the year for the patient enrolled with you. Then you'll get eligible for the annual service fee. So I hope that answers. Yeah.
Very good. I think that's quite clear for our audience. Okay, we have my favorite question, NEHR. I'm not sure why we are talking about NEHR, but I think maybe they are talking about the context of GPFIRST. They referred the patient to A&E and they are worried about the patient and they want to check the outcome by opening NEHR the next day, right? So this question is about the use of NEHR. Are they allowed to open NEHR after they have referred the patient to the A&E? Or must the patient be physically with them in order to open NEHR? So I may invite Prof. Gerald Koh, I think. High level question.
So when
on appropriate use.
Is enrolled to you, you should be able to look at the NEHR and whether or not the patient is physically in front of you or not.
When there is an indication. Dr. Suraj, you are in the NEHR work group also, right? So Dr. Suraj, you're here with us? Yes.
Yeah, let me answer that. I think the primary focus of NHR is that the patient must be under your care.
Yeah.
Right.
So,
Yes,
yeah, so sometimes you might want to follow up on what's the outcome of the patient. If the patient is under your care, you can do so. There's nothing they say you can't, as long as you can justify that the patient's under your care. Of course, if you discharge the patient and the patient's no longer under your care, then there's a it might not be so clear cut that you can access the NHR. But the guiding principle is that as long as you're treating the patient and you're looking after the care of the patient, you have every justification to go in and check the NHR. In fact, in the guidelines itself, sometimes we have also discussed that if the patient is referred to you, especially the under HSG, and then the patient is about to see you, there is some leeway where you can access the records before the patient sees you, but there must be a clear appointment made, because sometimes you want to prepare for the consultation first by looking in the NHR, especially, for example, the patient's already in the waiting room, waiting to see you, and you can actually access the NHR even before the patient sees you.
Okay.
So anyway, just for everybody's information, the work group is coming up with a guideline on NHR use, and to answer all these questions specifically, it'll be coming out soon, because now it's still going through a consultation process. And not to worry, because there are other questions about NHR, such as the legalities and whether you're obligated to check every patient the NHR status. It's not actually required, as the judgment is up to the doctor. There's no compulsory checking of NHR for every single patient, only if you think it's going to enhance your patient care. So questions like that will be answered with the guideline. Over.
Okay, good. So both Prof. Gerald and Dr. Suraj gave us a very reassuring answer. If there is a valid reason to open the NHR, especially if it's pertaining to the care of the patient, for instance, you refer to patient A and E, you're worried the patient didn't go, or you're worried about the well-being of the patient, and you document it down clearly in your notes, because sometimes you get audited, you want to pull back the notes, why they're open on this day, then I think it's justifiable and it's fair. Nobody will fault you about it. But if the patient is not under your care, it's your relative, you are checking for relatives and friends, all this, then please don't open the NHR. So the patient need not physically be in front of you in order to open the NHR, but you must have a valid and appropriate reason to open the NHR. And for valid and appropriate reasons and scenarios, do watch out for the upcoming launch of the NHR guidelines, and then that will be helpful. I think we are coming to a close already. I do not wish to drag hold on everyone out, because it's been a long day. So I'd like to thank everyone for your time, for joining, and all the questions. Do help us to answer the feedback poll. And while everyone is answering feedback poll, please remember to scroll down to answer all the feedback poll questions. There are just 10 very short questions. That'll be very helpful. May I invite each of the panelists, who have anything important to say your last words, not last words, your summary points. Press your key summary point, takeaway message for all our audience, your key summary, one learning point for our audience while they do the poll questions.
I think the health plan really, once you start getting into it, it's not onerous at all. It's part of the your regular workflow in the past 2 months, and it really is an opportunity for you to get to know your patients, open conversations, and also invite new patients to come into your list, so that you can apply the Healthy SG plans for them. Thank you very much.
Thank you. Dr. Tam, one learning point or reflection for all our PCN clinics and our GPs who spend the night today?
Yeah, I thought I just want to emphasize again that enrollment is about the principles and practice of family medicine. It's about primary care enrollment. It's about continuity of care by GPs and the polyclinic colleagues for our patients in the community. Always bear that in mind. And I think there are some challenges in terms of having to adapt to a new kind of ecosystem and a new way of doing things. Hopefully, the participants continue to join us for the subsequent webinars, whereby we will be looking into the sharing with you how we're going to tackle some of the care protocols, so that give you a bit more confidence as you embark on this journey, Healthy SG journey. Over.
Thank you. Dr. Ruth, please share some learning points for our GP attendees.
Let's say thank you to everyone for spending the night with us after a long day at work. If you've missed anything, there's actually these sessions are recorded. You can go to the college website or you can go to the AIC site to look at the recordings, and that's probably a useful resource because we can never remember everything at the first go. Thanks, everyone.
Thank you. Okay, thank you, everyone. Just to reassure, we'll be giving you the CME points. Don't worry. Okay, I think we have helped you enough. We have met the SMC requirement for CME points. We shall now release you all to have a good night. Thank you so much.
Johnson?
Oh, yeah, Marine, you want to say something? Yes, please
Yeah,
feel free,
no,
Marine.
just to let Dr. Chow know that he actually can go and find his account manager at AICAM Finder. And from there, he can type in his clinic and actually know who is his account manager if he wants to know about the national scheme. So I just want to say this. Thank you.
Yes, very good point. So everybody needs the AIC account manager. Please find out who your AIC account manager is.
Yeah.
He
So
trusts
just go
me.
to the AM Finder.
AM Finder. Okay.
In the internet. Yeah.
Yes, and AIC manager is everyone's best friend, right? Everyone's best friend, followed by the PCN leader and the PCN nurse counselor, the three most important best friend for anyone, right?
Yes.
Okay,
Yes.
so yeah, go for it. Make friends with AIC, make friends with PCN, and make friends with nurse counselor. Very important. Okay, I'm sure we got the CM points ready. We have enough attendance. Okay, thank you so much. Do join us for the next session. Thank you. Good night, everyone.
Thank you. See you next Wednesday.
Bye.